Good morning to Adrian and Mike, and welcome to 5 Minutes With this morning. And we're joined by Professor Mike Polkey. And if you would like to just introduce yourself, Mike, and tell us what you do.
Sure. Well, it's a pleasure to be here. I'm a consultant physician. I have an interest in sleep medicine of all types. But I think for the purposes of this discussion, we're focusing on sleep apnea, which is a very common problem. I have some insight into how it works because I work both here in London, in West London, and also in the Highlands of Scotland.
Yeah, that's a really interesting span for the remote and rural versus the inner city, Mike. It must be quite. Do you see big differences in the way services are delivered then?
Yes, I do. Although I think I also see a convergence, and I think that's one of the interesting areas in the field. So in the 20th century, when I started working, we still very much have, if you like, the Dr. Finlay model, where somebody would come to you with a problem, the doctor would arrange some tests, they would then bring the patient back and you'd see them again. And the reality is that there are too many people with sleep apnea for that to be a viable way forward for everybody. Some people will want it because they like the personal touch or they have special needs, but the vast majority of uncomplicated patients, there just are not enough doctors and nurses to deal with the problem in that way. So in the future, I do see more scope for automation, for multi-professional working, where perhaps the first person you see won't be a doctor, maybe an allied health professional of some sort, and I see scope for reviewing data in bulk at multidisciplinary meetings, really with an effort to try to bring this diagnosis and therapy out of a specialist centre, which is kind of where it started, and maybe more into the world of general practice and community therapies.
Yeah.
I couldn't agree more.
Yeah, have you any questions you want to ask Adrian?
So, yeah, I mean, my particular interest is in community pharmacy as the front line, where people go. So at the moment, my view is that community pharmacy, unfortunately, is misinformed, not just uninformed. I'd like to see that change.
I think that's one of the really interesting things about sleep apnea, which is the condition that we're talking about. And I think there are really three main reasons for treating sleep apnea. One of them is snoring, and arguably, in some ways, that's the least important, although anyone who's slept with a snorer may disagree. But the two main reasons for treating sleep apnea really are either to do with cardiovascular risk, and we can talk about that, but that's very pertinent to pharmacies, Adrian, because of course people go to the pharmacy to pick up their medicine for their high blood pressure or whatever.
Absolutely, there's your chance.
And of course the other reason for treating sleep apnea is to improve the quality of sleep, and therefore by extension one hopes the reverse, the level of vigilance and, if you like, vavavum during the daytime. And those are importantly different things in some ways, because the sleepiness will improve almost immediately, sometimes within a week or two if you treat the right people correctly. On the other hand, we know that the cardiovascular story is contentious, but certainly you're not going to reduce your cardiovascular risk in a couple of weeks. We're talking more like months and years.
Yeah, I mean, that brings us quite nicely on to the conversation about the Awake Check study and what we're trying to do with this particular piece of research. Adrian, do you want to say something as the project lead?
Okay, so the Awake Check is a simple 5 minutes tool. It's free, it's anonymous. It combines the stop bang as a level of risk for obstructive sleep apnea or sleep-related breathing disorders, and the insomnia severity index. The point of it is we're trying to get to the point where we can talk about at the current level of the risk across the UK. That's it, really.
Yeah, sure. And I mean, again, for your viewers, the general consensus figure, a lot of different figures come from different sources, but it's probably 80 or 85% of people with sleep apnea are undiagnosed. And part of that problem is diagnostic capacity, and waiting lists which are long in most parts of the country. But the other part of the problem is actually simply people realising the problem. And I think one of the key things about this condition is that it tends to creep up on people a bit unannounced. And the literature would say that people have often had symptoms for 5 or 10 years before they see a specialist, and that certainly fits with my anecdotal experience. And I think the reason for that is the sort of peak age that people tend to get this, typically in their, say, 50s, is a time where they have a lot going on in their lives. So, in essence, if they're feeling a bit rubbish, it may, in their own mind, it may seem to be that they're getting older, they have pressure of work, perhaps more responsibility at that age. People often, depending on their circumstances, have elderly parents who are a cause of concern, or sometimes they have wayward children. It's the time when relationships it's a time when relationships sometimes break down. So there are lots of reasons why people in their late 40s, 50s, early 60s may feel that they feel a bit rubbish, and so it's easy to put it down to that. And of course, sometimes it is just that. But equally, it may be sleep apnea, and when it is sleep apnea, it can be treated and improved. So
and you feel so much better. That's the point.
I think it's also fair to say that sleep apnea is sort of an iceberg disease, and so not everybody who has sleep apnea is sleepy, and not everybody with mild sleep apnea needs treating. But there's no doubt at all that if you treat the most symptomatic patients, the improvement can be life-changing. That's not true for everybody. And coming back to your question, Phyllis, about what are the important issues in the field at the moment, I think one of the issues is our main core treatment, which is CPAP. I mean, obviously we can talk about other treatments, but CPAP is still the mainstay of treatment. We know that after a year, only about 50% of people are adherent to therapy, and we need to work out whether that's because they find the therapy is not working for them, whether it's too hassly, or whether we've actually just treated the wrong subset of patients in the first place. So there are
there's all sorts of questions in there.
Further scientific questions to ask. Yeah, I mean, my hunch is that these figures, which are in the UK but also global, is that some colleagues possibly treat patients with disease who's too mild to warrant treatment, but working out beforehand who those people are is difficult, and sometimes people with apparently mild disease love the treatment and stay on it and are very happy with it, and we have other people with disease that you would consider very severe who, for whatever reason, don't get on with it.
Yeah. Well, thanks very much.
We should wind it up at that, and thank you so much for joining us. And there we go. awakecheck.co.uk is this is the awareness and the beginning of the journey. So thank you very much for joining us.
Very much for joining us, Professor Polkey.
Pleasure.
Take care. Thank you now. Bye-bye.
Thank you. Bye-bye.